Welcome everybody to this webinar organized by the International Society of Gynecological Endocrinology. My name is Tommaso Simoncini and I'm going to be the chair for this session today, which is going to be a wonderful session. The webinar today is about progestogens and it will dwell on the many reasons why progestogens are not A and what those differences between different types of these so important molecules in different areas of women's health. This symposium is organized by our society, the International Society of Gynecological Endocrinology, with the support of ABBOTT, that I would like to thank for their generous support. I know there is going to be a vast number of people listening to this symposium, so we are really thrilled. And I'm sure that two speakers that we have today to present science and clinical information that are going to be extremely important for everybody. I'm sure they will be able to entertain everybody. Indeed, we do have two absolutely outstanding speakers, Professor Johannes Ott from Vienna, Austria, and Professor Andrea Genazzani, who is also the president of the International Society of Gynecological Endocrinology. So I'm sure that most of you know both of the speakers. So I'm the chairman, so I don't want to steal time from the actual presentation and from discussion. We will have discussion at the end of the webinar. Just an housekeeping information. This webinar is translated in 6 different languages, so you have to select the right channel if you want to listen to the presentation in your own language. So let me start by presenting our first speaker, Professor Ott. Professor Ott is Associate Professor of Obstetrics and Gynecology and the Deputy Head of the Clinical Division of Gynecological Endocrinology and Reproductive Medicine at the Medical University of Vienna in Austria. He's authored more than 100 peer-reviewed articles, and the focus of his research has been on PCOS, polycystic ovary syndrome, fertility surgery, recurrent miscarriage, artificial reproduction, thyroid dysfunction, and autoimmune thyroiditis. So, Professor Ott, the floor is yours. And please, if you want, whenever you want, share your screen and start presenting.
Thank you very much for your kind introduction. Hopefully you can see my slides right now. I want to start to thank the organizers for the opportunity to be part of these precious ISGE courses. That's a great honor for me. And now let's start with the topic. Dear colleagues, my today's talk will be about luteal phase effects and pregnancy. And first of all, I want to start with a disclosure of my interests. And since the whole session is mainly about different gestagens, so not every progestagen will be the same, I will directly switch from luteal phase effects to luteal phase defects because we need something that we can treat. So let's begin with a few data on general background about luteal phase defects. So many of us think that luteal phase defects are equal to luteal insufficiency. In other words, a lack of progesterone. And this points towards something very important. The clinical pattern is not well described. And so some people even ask whether luteal phase defects would really exist or would only be a myth. The term has been used for the first time in 1949, and basically luteal phase defects are characterized by an inability to develop fully mature endometrium. However, as mentioned before, these LPDs are poorly characterized as a clinical entity. Thus, I want to give you some insight into these considerations. Basically, 2 major mechanisms have been proposed, namely an inadequate endometrial response to progesterone and an inadequate corpus luteum function. And the latter has been linked to several other abnormalities. These include decreased FSH levels in the first half of the cycle and abnormal LH pulsatility. We'll come back to this later. Decreased LH levels during the ovulatory surge and elevated prolactin levels, among others. that a sufficient corpus luteum function in terms of adequate progesterone levels would be favorable, especially in a woman who wants to conceive, has been proposed for many times. This study, for example, demonstrated that women with a mean luteal progesterone level exceeding 8 nanogram per milliliter would have a higher chance to achieve pregnancy within the next 2 years, but this is only one of many reports. But this brings us to an important question. How is progesterone built in the ovary after ovulation, and on what stimulus is this production based on? What you can see here on the left and on the right side, these are two examples of patients, is that rises in LH, which are likely due to rises in GnRH, are necessary for a rise in progesterone secretion from the corpus luteum afterwards. We consider the woman on the left side to seem to have a good progesterone secretion. The levels are much higher than in a woman on the right side. Whereas in this woman on the right side, this does not seem to be the case. And the woman kind of totally lacks LH increases, which you can see here, and thus also progesterone increases. So basically, we do not know the exact underlying mechanisms, but physical and psychological stress, as well as hyperprolactinemia, have been associated with a decrease in GnRH positivity, also in the luteal phase. When we come back to these slides, to these figures that we already saw, something else becomes evident, namely that one single progesterone measurement carries the risk of a false negative or a false positive result, because a part of the corpus luteum function depends on these before mentioned LH searches. For example, if we have the woman on the left side, you could come early and your testing might suggest luteal deficiency, although afterwards there would be sufficient progesterone levels. And the opposite could be the fact in the luteal deficient patient on the right side. And the curves that you saw in the last slide, they derive from the fact that basically there are two sources of progesterone secretion and production in the ovary. First, we have the small luteal cells, which originate from the granulosa cells, and they contribute to progesterone secretion with a basal production, quite independent from LH. And what you can see here on the right side are the large luteal cells, which originate from the theca cells. And like the theca cells, these cells respond to LH, and they respond to LH with an increased estradiol and progesterone production. And that starts from the 4th to the 6th day after the ovulation. So if you have a problem with the large cells, so that could be more or less due to a decrease in GnRH frequency, or a failure to respond to these LH pulses. And if we have a failure on the left side with the small luteal cells, then this is likely to be caused by ovarian causes, which means accelerated luteolysis. However, and this is very important, basically, as I said before, the definition luteal phase defect is not based on progesterone levels, but on histologic analysis of the endometrium in the luteal phase. A lag of more than 2 days in the endometrial development compared to the time of ovulation is the main accepted criterion nowadays. And unfortunately, this should be present in more than one cycle due to intercycle instability. You can see here that many women who have this problematic lag time in the next cycle will have a normal endometrial development, and thus it is considered that 2 of these pathologic and abnormal measurements would be necessary to correctly diagnose. But of course, this is hard to assess. Thus, we have to ask ourselves, are there any reliable indicators? And since I don't want to waste your time, in short, I just want to tell you, body temperature, that's not the solution. It's not useful. So as I said before, endometrial histology could be useful since it is the main diagnostic criterion. And despite that you have a significant intra and inter-observer disagreement in this assessment, the results are still highly reproducible. And as I said before, the last ovulation should be your reference date or the reference date of the histopathologist. However, as I said before, that's hard to do, and it would be much easier to use blood sampling. However, as shown before, the serum progesterone levels reveal large fluctuations due to the pulsatile GnRH and LH releases. Thus, it has been mentioned that it would be optimal to use 2 or even 3 blood samples within a few hours. And of course, based on what I said before about the large cells, this should be done 7 days after the ovulation at the earliest. The most accurate cutoff values to predict luteal phase defects in histology would then be 10 nanogram per milliliter if you used a single measurement. And if you're using a sum of 3 repeated measurements, then of course, accordingly, it would be lower 13 nanograms per milliliter. And thus, apart from histology, progesterone seems to be the only reliable non-histologic method, since all other tools are, as I said before, not reliable enough. So having said this, let's dive into the therapeutical aspects of this knowledge. Luckily, there are 3 relevant clinical patterns concerning fertility and pregnancy. First, infertility, sterility, mainly unexplained infertility probably, then luteal support after artificial reproduction, and last not least, recurrent miscarriage. So we'll start with infertility. Just a short overview from an old publication. It has been demonstrated that the rate of women with luteal phase defects would be higher in women with infertility, with about 12 to 13%, and the highest in women with recurrent miscarriage, with up to 30%, when compared to fertile controls. However, and this is important to know, it has been demonstrated that the rate of women with luteal phase defects would be higher in women with infertility, but not all women with infertility who have such a defect then have a problem with getting pregnant. Some studies even demonstrated that the presence of an out-of-phase endometrium might not alter the pregnancy chances, and that even when the women would get pregnant, the chances of a miscarriage would be the same. And that even applied, going back to that slide, to women who had their endometrial biopsy in the cycle of conception, which is a study which would be hard to conduct nowadays, I guess. However, although luteal phase defects per se did not decrease the chance for pregnancy or a live birth in all studies, it remains very likely that at least more severe luteal phase defects with a very large and big lag time play a role. And despite all these uncertainties about the impact of luteal phase defects on fertility, there is interesting and noticeable evidence from IVF cycles, especially frozen IVF cycles and donor cycles. This evidence suggests that progesterone is of major impact due to the fact that in women without a basal hormonal production, namely women with hypogonadism, higher implantation rates could be achieved with the use of artificial estradiol and progesterone supplementation compared to normally cycling women in some studies. You can see an older study here. And thus we rely on pathogenesis-oriented treatments, although in the case of infertility, overall infertility, unexplained infertility, we do not have good data which provide a rationale for giving our patients luteal support. So what we can do is provide an estrogen, progesterone replacement, probably ovulation induction, luteal support with HCT, GnRH pulses, and the lowering of prolactin levels. In clinical routine, at least in the German-speaking countries, many institutions offer clomiphene stimulation, letrozole stimulation, or luteal phase support alone, even that, to couples with unexplained infertility, despite the low evidence. We only have a few retrospective data which, for example, show that dydrogesterone supplementation would be beneficial after letrozole stimulation for polycystic ovary syndrome, for example. However, we do have much more evidence from the IVF cycles. And this is what I want to focus on next. It has been claimed that women undergoing IVF might suffer from luteal phase defects more often due to several specific problems, namely, and first and foremost, multifollicular development, which would lead to negative feedback on LH secretion via cyprophysiologic estradiol serum levels, the disruption of granulosa cell function mechanically after oocyte retrieval, and many more. And it has been demonstrated that with the use of luteal phase support with any kind of progestogen, you can increase the rates for ongoing pregnancy and live birth rates after IVF. However, as also shown in this Cochrane database analysis from 2015, the effect is only modest with an odds ratio of about 1.8, sorry. And this supports the often mentioned theory that in the majority of patients who undergo fresh cycles, the natural luteal function would be sufficient, and only a minority of these patients would then profit from luteal phase support. As you all know, there are several routes for progesterone administration: intramuscular, vaginal, subcutaneous, oral, transdermal. And we're lucky that we have several good analyses available to compare these schemes. In a very good meta-analysis of 2009, which you can see here, the vaginal and the intramuscular applications were compared to each other. The effects on clinical and ongoing pregnancy rates were comparable. However, the data favored intravaginal progesterone in terms of a reduced miscarriage rate. It needs to be emphasized that in these days, a progesterone gel instead of capsules was used, and that might alter these results regarding to the capsules of various producers that we have available nowadays. In the last years, experts have discussed whether oral dydrogesterone would be as effective as vaginal micronized progesterone. How come? According to a meta-analysis in 2015, both regimens, you can see that here, would be similarly effective in terms of clinical pregnancy rate. However, the data clearly favored oral dydrogesterone in terms of patient satisfaction, which of course sounds kind of reasonable. And thus, Professor Griesinger and colleagues were able to publish their randomized study in 2018. And finally, they were able to show, which is very important in my eyes, the non-inferiority of oral dydrogesterone compared to vaginal progesterone in this very large study of about 1,000 patients undergoing IVF treatment. And now, although we can say that the majority of these preparations used seem to lead to similar conception and live birth rates, many experts can rely on the existing data that the oral application of dydrogesterone is reliable. You see the treatment doses here. There is one additional very important comment in my eye. We have a very new publication which appeared a few months ago in the American Journal of Obstetrics and Gynecology. And this said that the intramuscular application of hydroxyprogesterone caprate might induce malignant diseases in the offspring. So probably that won't be used in the future anymore. I just want to focus on other treatment options for luteal support too, just in short, due to its structural similarity to LH. HCG has been claimed to be useful. This is also suggested by the already mentioned Cochrane database with a moderate odds ratio. You can see that here of about 1.8 for ongoing pregnancy rate. However, these are data which compared HCG to placebo and not to progesterone use. However, when progesterone is already provided for luteal support, very important to know, additional estradiol treatment does not seem to increase the pregnancy rates. However, an additional application of GnRH agonists might even improve the pregnancy rates, and we have an even more recent meta-analysis on this topic, which also demonstrated that the combination of progesterone and the GnRH agonist for luteal support would not only significantly improve the live birth rates, with also again a moderate risk ratio of about 1.5, but also clinical pregnancy rates and a tendency to a decrease in the miscarriage rates. Last not least, let's come back to miscarriage and recurrent miscarriage. As you all know, the higher the number of the previous miscarriages a woman has suffered from, the higher is the risk for an euploid miscarriage. And luteal phase defects have been claimed to play a major role here for a very long time. As already mentioned before with this slide, these luteal phase defects seem quite common in women with recurrent miscarriage, with a prevalence of up to nearly 30% in reasonable studies. It has been mentioned that to overcome problems with FSH levels and the LH surge around ovulation, that to overcome this burden, it could be possible to give FSH or low dose treatment even to these patients. And we have a few studies here like this which show that the rates of LPDs decline afterwards, after such a stimulation. However, the main approach, especially in unexplained recurrent miscarriage, is luteal support again. And according to the PROMISE trial, which had been long awaited, 2 vaginal capsules of 200 milligrams of micronized progesterone unfortunately did not lead to a beneficial effect in women with recurrent miscarriage. However, such an effect on ongoing pregnancy after 12 weeks was found in a meta-analysis in women with 3 or more previous miscarriages and not in other women. And the same was true for reduction in further first trimester miscarriages. And what we can say from a recent meta-analysis is that it is very likely, when you look to the slides here, that the use of any progestagen would increase the chance for an ongoing pregnancy and or live birth in women with recurrent miscarriage. You can see the pooled analysis here with small increase in the chance for getting a live birth with a relative risk of 1.06. However, the question is whether any kind, a specific kind of gestagen would be favorable over another one. For example, not showing that here, the German guideline still recommends oral dydrogesterone over micronized progesterone, which is based on several analyses, also other meta-analyses. It needs to be emphasized that in this Cochrane network meta-analysis, which was published in 2021, it has been stated that dydrogesterone would not increase the chance for an ongoing pregnancy in women with threatened miscarriage who had already suffered from at least 1 previous miscarriage. But in contrast, the use of vaginal micronized progesterone would do that with a slightly increased chance for live birth of 1.03, a relative risk of 1.03. However, in the situation of recurrent miscarriage, this network meta-analysis stated that none of the substances was found to increase the chance of live birth. So I'm aware of the fact that several meta-analyses are available which say that and come to different conclusions. And I'm aware of the fact that this is a question of studies which were included into this analysis. Personally, if you would ask me, what I'm doing right now is to prescribe both dydrogesterone and vaginal progesterone to my patients, but please keep that a secret and don't tell anybody, okay? So that was quite a complex talk, I guess, and I think that I'm in time. I think that I can conclude that luteal phase defects are not a myth, but reality. However, they remain poorly characterized and difficult to diagnose, since progesterone is not the perfect way to diagnose it. The best evidence exists for supplementation of vaginal micronized progesterone and oral dydrogesterone, especially after artificial reproduction and in the case of recurrent miscarriage. In IVF or after IVF, other treatment options also seem promising, like, as I said before, GnRH agonists or HCG. I hope that you were able to learn something from what I said and from my presentation. And I'm very looking forward to any questions afterwards. And thank you very much for your kind attention.
Professor Ott, thank you so much. Johannes, congratulations. It was a wonderful lecture, really a wonderful lecture. We already have a few questions, but I would suggest that we discuss the two topics after the second speech. So we have more time for people to think about questions and maybe to integrate between the two topics. So it's my pleasure and honor now to introduce Professor Genazzani. He really needs no introduction, but for me, it's something that comes from the heart, because Professor Genazzani is a lot of things to everybody. He's the president of the International Society of Gynaecology. He's the full professor of obstetrics and gynecology since 1980. And he's professor of obstetrics and gynecology everywhere in the world, because he's received so many honoris causa lecture laureates that I've lost the number around the globe. He's also editor-in-chief of Gynecological and Reproductive Endocrinology and Metabolism, and previous editor-in-chief of Gynecological Endocrinology. He's also now editor-in-chief of Frontiers in Gynecological Endocrinology from Springer. And he's authored more than 150 papers and a number of books. But most of all, he's been my master. So I've been working with him for more than 20 years. So it's a particular pleasure and honor for me to introduce Professor Genazzani. Professor, please.
Thank you, Tommaso. I will go to share my screen now. And I was requested to speak about that not all progesterones are the same, and to speak about what happened in climaterium and menopause and why the progestogens are of great importance. First of all, as you know, I am in favor of the use of menopause hormone therapy because it's the most effective treatment for menopausal symptoms and can be really done by the majority of women. And this is a feature that you know, that menopause hormone therapy is able to face the treatment of the vasomotor symptoms, but not only, decreases incidence of all fracture, and have profound effect on joint pains, mood swings, sleep disturbances, sexual dysfunction improvement. And I remind you that non-hysterectomized women using estrogen should use progestogen to minimize the endometrial risk. This was the major reason why progestogens are included in menopause hormone therapy. As you know, what is the role of the progestogen? Estrogen provides the benefit of menopause hormone therapy on menopausal symptoms, but as mentioned, for the women who have not had an hysterectomy, the addition of a progestogen to menopause hormone therapy is necessary to protect endometrium from the stimulatory effects of unopposed estrogen therapy. You can see here the comparison between the use of placebo, CE alone, CE plus medroxyprogesterone acetate sequential, or continuous, and you can see that the histological picture of the endometrium, the data originating from the PEPI trial, they should be normal, single hyperplasia, complex hyperplasia, atypia, and also adenocarcinoma. You can see that placebo, the result, the CE alone, they can increase the number of complex hyperplasia and atypia. CE plus medroxyprogesterone acetate, you have no more cases of atypia. And if you give it continuously, you have only normal endometrium and very rare, only 1% simple hyperplasia. Then the conclusion was in PEPI trial since 1996 that adding a progestogen is needed to safeguard the endometrium. But, you know, why? Because the progestin, they have a direct anti-mitotic effect on glandular epithelial cells. Then they stop the mitosis in G1 phase, stop the DNA synthesis, and decrease the estrogen receptor synthesis. And they induce the differentiation, then the secretory changes of the endometrium. But progestogens are many. As you know, progestogens, they have been synthesized from the industries from several precursors. Some of them originate from 17-hydroxyprogesterone, such medroxyprogesterone and cyproterone acetate. Some are 19 progesterone derivatives, such normegestrone and progesterone. Some are derivatives from testosterone, and their structure is related to testosterone, either from 19-nortestosterone, such norethindrone, dienogest, and tibolone, or they are the estradiol and asgonane, also levonorgestrel, or some are derivative from spironolactone, such drospirenone. In addition to that one, we have the structure related to progesterone is the stereoisomer dihydrogesterone, called also retoprogesterone. What is the effect of these different progestogens and why they are so different? They have distinct biological activity, and the different biological activity depend on the chemical structure and depend from the intracellular action, which is mediated via the progesterone receptor. Just to give you an image, progesterone, cyproterone, and MPA, they interact also with glucocorticoid receptor in addition to react with progesterone receptor, while levonorgestrel, norethisterone, and MPA, they interact also with androgen receptor in addition to the progesterone receptor. Dihydrogesterone, drospirenone, dienogest, and progesterone, they interact with progesterone receptor. This, the fact that this molecule can have other binding sites, such androgen, glucocorticoid, or mineralocorticoid receptor, this is the cause who make the difference between the different biological activities. And you can see here, this is a picture of all the progestogen used, starting from micronized progesterone and all the possible receptor activity, which should be progestogenic, estrogenic, androgenic, antiandrogenic, glucocorticoid, and mineralocorticoid activity. You can see here that micronized progesterone have a progestogenic activity, a slight antiandrogenic and glucocorticoid activity, and a slight mineralocorticoid activity, while dihydrogesterone have only mainly the progestogenic activity and very minimal activity in the other side. Other progestogen, I want just to mention cyproterone acetate, they have stronger progestogenic activity, but they have also even more stronger antiandrogenic activity and some activity on glucocorticoid receptor, such medroxyprogesterone acetate, we have a very strong activity on glucocorticoid receptor. This is the reason of the difference at the biological level of the various progestogen used. And you can see here that all the gonane, for example, they have a strong progestogenic activity, but they have also some androgenic activity and some glucocorticoid activity. While drospirenone have a progestogenic activity, a slight antiandrogenic, and an important antimineralocorticoid activity. All this is the cause of the difference that you see in the receptor. Looking now to the dihydrogesterone, dihydrogesterone, you know, is a stereoisomer of progesterone. And you can see that it's selective for the progesterone receptor, reducing the likelihood of other receptor-related side effects. But you can see that have a very profound difference in comparison to progesterone. You have a progestogenic effect. You have the ovulation blocking effect, which is typical of progesterone. It is not acting on thermogenicity. You have not antigonadotropic activity. You have some antiestrogenic, and you have no estrogenic, no androgenic, some antiandrogenic, and some antimineralocorticoid activity. The fact that it cannot block ovulation and it cannot interfere at central level, this is the reason why we can use dihydrogesterone also, as it was mentioned by Professor Ott, in the late phase of follicle maturation without affecting gonadotropin release. Speaking also about dihydrogesterone, it's important to note that it have 5.6 times higher oral bioavailability than oral progesterone. And this makes that the oral dihydrogesterone is more potent given orally, and then this provides us the possibility to reduce the dose of dihydrogesterone in comparison to progesterone. Speaking about the progesterone and progesterone metabolites, they are important, also important to be aware what are their neuroendocrine effects. I was mentioning that progesterone and also its metabolites, they can have either genomic action, either non-genomic action. And this action bring to, they can interfere with the GABA-A receptor, they can have a GABA-A agonistic effect with a GABAergic anxiolytic effect, they can interfere with monoamine oxidase and catechol orthomethyl transferase activity, then touching the turnover of noradrenaline and dopamine. They can interfere with serotonin turnover, then they should also have an effect on mood disturbances. They can act also on the production and activity of central opioids, then they can interfere in mood and pain threshold, and they can also have an effect in the production of some neuropeptide. I mentioned the brain-derived neurogenic factor that we have published the data, and then this can bring to the progesterone metabolites an effect on integrate neuroendocrine function and cognition. And, you know, for the progesterone is also important, the longer half-life who allows a single daily administration and improve compliance. And the prolonged half-life is more important than the dose needed to protect the endometrium. I just want to mention for you the different duration of half-life and the equivalent dose. You can see here ciproterone acetate have an half-life of 48 hours. And if we take an equivalent dose of 1 milligram of ciproterone acetate, you can see here the important changes of all the other. Just to mention, the half-life of nomagestol go from 30 to 50 hours, to armadinone acetate 34 to 39, to spironolactone 30, norethistérone 80 to 26, MPA 14, dienogest 11, dydrogesterone 2.56, and micronidroprogesterone only 2. And this is the reason why the equivalent oral dose is so different from one to the other. But then now going to the possible problems that the women are looking. You know, one of the major problems for menopause hormone therapy is the fear that the women have for breast cancer. And then if we move from laboratory to clinical practice, you can see here, this is a resume of all the studies going from 95, then from the NURSEL study till the 2019 paper published on individual participant meta-analysis of more than 500,000 papers speaking about the difference about progesterone. You know, if you look all this study, we have seen they show that it exists an higher risk of breast cancer with estradiol or estradiol plus progesterone, but they don't bring any real focus on the individual progestogen. While in the study published in 2019, the Lancet meta-analysis on breast safety, you can see here that when they refer cases treated only with estrogen-only preparation, either equine estrogen as well estradiol, you can see that in that study, they have a slight increase in both constituents. And, but they have seen also that related to the mode of administration, even though in this group, the transdermal group was very smaller in size, they seem to indicate that both oral and transdermal, they have a slight increased risk. And when you speak about the combination with the progesterone preparation, you can see that they using levonorgestrel, norethistérone, and medroxyprogesterone acetate, they have an increased risk with all progesterone used. Then micronized progesterone and dydrogesterone were considered in this study rarely used hormones. Then the data are not referred. But when we go to see the important WHI result at the end of the story, in the WHI, it was clear that CE plus MPA have a slightly greater incidence of breast cancer, but no difference in breast cancer mortality. This was something important. While if you give CE alone, we have a lower breast cancer risk and lower breast cancer incidence and lower breast cancer incidence. This brings up to that consideration, the same treatment with the addition of medroxyprogesterone acetate is associated to an increased risk. Then this seems to advocate more to medroxyprogesterone acetate, the capacity to have to bring the risk instead of conjugated equinestrogen. But looking now to the more recent data on combined menopause hormone therapy, who indicate, in fact, that they are not all the same. Please look at that one. This is the data published on the recent use. You can see used less than 1 year, from 1 to 4 years, and more than 5 years of medroxyprogesterone acetate. This is associated to an increased risk of levonorgestrel, similar groups, and also similar size of population. Of noretisterone acetate, you have that 1 to 4 years and 5 years also slightly increase, while dydrogesterone, less than 1 year, 1 to 4 years, and plus than 5 years, they have lower of no increased brain crescent risk compared to medroxyprogesterone acetate, levonorgestrel, and NITA. And when we go to see the effect of the past use, in women who had for less than 1 year, 1 to 4 or plus than 5 years with medroxyprogesterone acetate, you can see that we have no levonorgestrel after 5 years show in this population that the past use is also associated with an increased risk, also with a longer exposition to noretisterone acetate, but no with dydrogesterone. Then menopause hormone therapy with dydrogesterone had no increased breast cancer risk compared to estrogen only. This also corroborates the concept that different progestogens, they can bring different effects. And also another important study was to compare the menopause hormone therapy according to the early menopause. You know, to have a treatment in early menopause, in medroxyprogesterone acetate, in levonorgestrel and noretisterone, they have a slightly increased risk compared to estrogen only, while if you give dydrogesterone, this is not associated to any increase in the risk. And also this brings an attention to the fact that the different progestogens, they can be for the breast with different possible risk in comparison to natural progesterone and dydrogesterone. Then the take-home message is that all progestogens are not the same. Menopause hormone therapy and breast safety data is lower of no risk with dydrogesterone or micronized progesterone, slightly increased risk with levonorgestrel, noretisterone, and medroxyprogesterone acetate, and positive of data with Genazzani, drospirenone, and ciproterone. Then long-term menopause hormone therapy have to be done with selected progestogen, and in that way is safe. And I would like also to bring your attention on an aspect is cardiovascular risk. You remember that WHI, when it was launched with the idea that he can have some risk on cardiovascular level. All the studies now, they have, after 18 years, they have agreed that it is not true. But in fact, all our European studies, I want to mention the beautiful study from the group of Tommy Mikkola, have shown that not only we have no risk, but if used in younger postmenopausal women from 50 to 59, we have a 40% reduction of the cardiovascular diseases. And also if used from 60 to 70 years, this remains around 30% reduction. And even in women over 70, the risk reduction is around 20%. Then estradiol-based hormone therapy are accompanied with larger coronary heart disease mortality risk reduction the earlier the therapies are initiated. And the progesterone component in estrogen progestin therapy in our study do not modify this timing effect. Now going to another chapter. As you know, oral estrogen, they are associated to an increased risk in venous thromboembolism. And it was shown by the French prospective cohort study from Canonico and collaborators. Then oral administration of estrogen bring this risk, while these do not happen if they use transdermal administration of estrogen. And the association of progesterone and progestin indicate that progesterone and pregnans are not have no increased risk, while the addition of norpregnans increases the risk. The same or similar data they were also present in the Million Women study. You remember that study published on Lancet? He have shown that oral estrogen plus progestin therapy have nearly twice the risk of venous thromboembolism, oral estrogen only 1.4, and transdermal estrogen no increase in the risk. And the addition of norethisterone or levonorgestrel, these do not modify the oral estrogen risk, while the addition of medroxyprogesterone acetate increases even further. And these data correspond also to what we have seen published by Schierbeck in the Danish osteoporosis prevention study. You remember that it was one of the studies fighting against the data of WHI. And they have found, related to the deep vein thrombosis, pulmonary embolism, and stroke, that the users in comparison of the non-user have an increases of deep vein thrombosis, but not of pulmonary embolism and not of stroke. And this was done by the oral administration of estradiol and norethisterone. And in hysterectomized women only with estradiol. And this brings to the concept that estrogen alone versus estrogen plus progesterone make a difference. The different pharmacological classes of progesterone, they can make a difference, and the difference exists also for the single molecule and also for the tibolol. And to assess correctly the impact of progestogen, it's necessary to take into account the route of estrogen administration and assess the impact of progestogen separately using oral and transdermal user. And then in oral user of estrogen, you have to evaluate in a different way of transdermal user of estrogen, also to better understand the progestogen role. And to estimate concurrently in a same model the main effect of estrogen by route of administration and progestogen. And you can see here, this is the effect of estrogen alone versus estrogen plus progestogen. You can get oral estrogen unopposed increases the risk, and also when they are opposed and you have a slight difference, then opposed estrogen, the risk is slightly higher. Transdermal estrogen, they don't have any risk. Transdermal estrogen with a progesterone, a slight increase, but absolutely lower than oral treatment. And then this depends also from the different class of progestogen. You can see micronized progesterone have no effect, pregnan derivative have no effect, while norpregnan derivative have a significant increase. That this means that different progestogen also interfere with venous thrombosis risk. And when we evaluate the hormonal therapy on activated protein C resistance, the impact of progestogen, you can see that in comparison to no treatment, transdermal estrogen plus progesterone have no effect, while transdermal estrogen plus norpregnan derivative have a significant effect, either in comparison also to transdermal estrogen plus progesterone, as well in comparison to no treatment. Then the norpregnan derivatives, they by themselves, they slightly increase the production, the effect on protein C resistance. And looking to medroxyprogesterone acetate and venous thromboembolic risk, you can see also in WHI study the comparison between CE alone and CE plus MPA. We have an increase in the risk. And in the Wisdom and the Million Women study, CE alone and MPA, still we have a difference, and also this exists also in Million Women study. Then the addition to MPA to CAE or oral estradiol increases the risk. For tibolone, you have seen that all the different studies using tibolone, they have found that we have no increased risk for venous thromboembolism. Then venous thromboembolism is the main harmful effect of short-term hormone therapy. Two important determinants of VTE risk are the route of estrogen administration, safety of transdermal estrogen, and also the concomitant progestogen. Norepinephrine and MPA could be thrombogenic. And in effect, this is about the stroke. You can see here, stroke and progestogen, the non-use, no risk of micronized progesterone and pregnane derivative, nor pregnane derivative, they can have a risk. And then to improve the benefit-risk ratio of hormone therapy, and then to reduce venous thromboembolism and stroke risk by two important determinants, the safety of transdermal estrogen, I remind the patch and the gel, high level of evidence for venous thromboembolism, and they are also suggested for stroke prevention. And also important is to take in mind the concomitant progestogen. We have to use those who have a well-documented reduction of venous thromboembolism, but we need further data for stroke because they were not analyzed. Then transdermal estrogen alone or combined with progesterone or dihydrogesterone could be the safer option. Then I remind you that the menopause in general is the cause of frailty, of vulnerability, of diseases, and changes in lifestyle. And we suggest that menopause hormone therapy as a solution. But the women may be differently vulnerable to menopausal changes. And then we don't have a standard therapy, but we have to adapt the therapy according to the characteristic of each woman. And the tips and tricks are to choose the natural route of administration, which should be the vaginal or the transdermal. Choose the right molecule, mostly estradiol, prefer vaginal progesterone, and if oral progesterone is needed, choose dihydrogesterone for cardiovascular disease prevention and lack of central effects. And then, dear friends, this is my conclusive slides that I take from a paper that we have published with our chairman, with Tommaso Simoncini and this group recently on human reproduction update, who support the fact that in premature menopause and in healthy women at menopause, we have to evaluate the case and we can start the treatment, and the therapeutic option are estroprogestin sequential or continuous. They should be oral, transdermal, or transcutaneous, then SEC, tibolone, and also remind topical therapies. We have to treat them, but 10 years after, we have to reevaluate the subject. If they are still healthy, we can continue with estroprogestin. They have to be given continuously, no more sequential, in an oral way, given better with a transdermal way or transcutaneous. We can also use tibolone and topical therapies. And that in women who just at the menopause, they are overweight, they have also a metabolic syndrome and other risk factors, then we have to treat the women for their specific risk, but we can absolutely start the hormone therapy, and the therapeutic options are the estroprogestin continuous or cyclical with transdermal or transcutaneous way and topical therapies. And 10 years after, we can reevaluate and we can go to, and if they are still well and still well respond to the hormone therapy, we can continue with an estroprogestin continuous, mostly transdermal or transcutaneous, no more oral. They have to be given transdermally in this patient. And also we have to remind the very important use of topical therapies. Then what are the conclusion and the new insight of healthy aging is we have to remind that behavioral interventions have to be used to improve quality of life, that the menopause hormone therapy is not a replace of lifestyle intervention, but have to integrate the lifestyle intervention. We have to remind the importance of primary prevention, but mostly tailoring the treatment, the window of opportunity, evaluate contraindication, evaluate risk related to comorbidities, and also the availability of several and different compounds which can be used. And with that, I thank you very much for your presence today, and I am ready for the discussion. Thank you very much, Tommaso.
Thank you very much, Professor Genazzani. That was outstanding, extremely extensive, and I think so. We have a lot of questions, which provides the flavor that everybody really appreciated your lecture and Johannes Ott's lecture. So we have time for a discussion. We have about I think 20 to 25 minutes or so, and I think it wouldn't be sufficient because we have a lot of questions. So let me start from the questions for Professor Ott. So we go to the first part on luteal function and luteal phase defects and the use of progestogens to that extent. There's a couple of questions from Professor Naftolin. He's always let me greet him wholeheartedly. One question is on the different roles of large luteal cells as well as compared to small luteal cells that Johannes, you mentioned. And he's asking, since the large luteal cells are from the thickener and responding to LH, could androgen measurement could be helpful in explaining and confirming luteal phase defect? That is a very clever question.
That's a very good question, and I don't think that there is any literature, any evidence about that. Probably nobody has ever looked at this. It has been mentioned that luteal phase defects are more common in women with polycystic ovary syndrome, who obviously have problems with androgen production and hyperandrogenism, but there are no direct correlations or something else from androgens, especially in the luteal phase with luteal phase defects themselves. So probably that's a very good idea for a clinical study.
Yeah, yes, I agree. That's a very great, that's a good suggestion. But Professor Naftolin is always a thinker. So
I like that.
What is simple, yes. It seems to be a very simple observation while it requires a lot of brain to get to that. So still Professor Naftolin, he's actually asking about your opinion on what is the actual mechanism for pregnancy failure in luteal phase defect. Are the embryos affected? Is the implantation normal? Does the uterus reject the embryo by shocking the embryo off through contraction? So what is the main, or what are the mechanisms?
Of course, that's also a very, very good question. I don't think that the embryo itself is affected. If we're going into the literature about that, there are some hypotheses about the effects. The majority of colleagues think in a more, let's say, mechanical way, and think that the implantation process is somehow interrupted or has a problem. There are some studies which correlate these luteal phase defects with immunologic phenomena. For example, chronic endometritis and also installation of the endometrium with cells, killer cells and natural killer cells and things like that. So both of them have been linked to each other. And in addition, there is the idea that probably it could be more common in women with adenomyosis. Then we also know women with adenomyosis and endometriosis often reveal as a light form of chronic endometritis that could also be a cause. So that's probably also something that needs to be said. It is very difficult to keep the causes and the effects distinguished from each other, because sometimes we have various associations of various disease patterns, and luteal phase defects probably only are of interest secondary to other problems. So we don't really know that, but the major hypotheses are about an effect on implantation itself.
Yes, very clear. A couple of questions on endometrial sampling. Do you think that implementation of endometrial sampling should become a routine in women with unexplained infertility?
Not right now. I don't think so. For various reasons. We have the data, for example, in the big randomized study about the endometrial scratch before every woman undergoing IVF, and it doesn't show any benefits. We have only data that in women with recurrent implantation failure, recurrent miscarriage, endometrial sampling could be beneficial, especially regarding chronic endometritis and treatment of chronic endometritis. But for the luteal phase defect, since we're providing luteal support and probably also other support to all of these women, I don't think for that indication, this should be a routine testing.
And the other side of the question, since we do know about the, we have hints that endometritis or inflammatory changes within the endometrium might be important in failure, particularly in medically assisted procreation techniques. So do you think that there's an association between infection of the endometrium and luteal phase defects induced chain modifications in the endometrium?
Yeah, this has been mentioned in a few reviews about the topic. The problem is I never found clear data about the association of chronic endometritis as it is diagnosed nowadays. So with this CD138 staining, that would also be a good study, I guess. We're already thinking about conducting such a study. I've guessed that we will need more data about that. So there are some hypotheses about that, and data and some experts suggest that, but we don't have sufficient data about that, unfortunately.
Okay. And lastly, a couple of questions on the ERA test and luteal phase insufficiency. Okay. Yeah. So one general question is, do you have any comment? And but from the same person, there's a comment that says that comparing ERA test for window of implantation has been found at 2 days out of cycle, and they move to an embryo transfer luteal phase defect is suggested that subcutaneous progesterone, and it depends on P4 levels to ACG application. What do you think? So in other terms, how do you use this ERA test in the setting of luteal phase?
Unfortunately, due to general restrictions, we cannot offer the ERA test at the Medical University of Vienna. Thus, I don't have experience with the ERA test, just theoretical knowledge. Probably Professor Genazzani, Andrea can help me out with that question, because probably you have experience with the ERA test and luteal phase sampling. I just know that there is one retrospective study which tried to compare the ERA tests with endometrial sampling, classic endometrial sampling, and found some kind of connection, but not a very strong one between the two.
No, I agree, absolutely. There is no further. We need more investigation on this point. The investigation, they're very limited also because, when we speak about the implant and possibility what can touch the endometrium for that moment, the sampling at the moment of embryo transfer, it cannot be proposed because this can be damaging the structure, and then you have to go in a different cycle. And a different cycle has different biological situation, also because the biological effect of progesterone and estradiol is also depending what happened during endometrial maturation until this moment. Then it's really very an individualized study and will have to be done for the different patients.
Okay, no, great. Thank you both for these clarifications. Now, let's move to a few questions on the menopause part of the talk and on the role of progestins. So there's a question that refers to women who have had an hysterectomy. The person who's asking the question wants to know if a patient has no response to estrogen for climacteric symptoms, flushing, so she doesn't respond to estrogen, would you add a progestin, and eventually which one and through which route, in order, I guess, to reinforce the response in terms of clinical complaints?
Certainly, yes. You have to give progestogen who can have an effect directly on the brain. Then I would like to suggest the addition of progesterone, because progesterone inside can be absorbed and inside to the brain can be easily transformed to allopregnanolone, and this can potentiate the effect of estrogen too. And then my suggestion will be in those patients to add transvaginal progesterone administration. Not so much oral. You know, oral is too short. The half-life of an oral progesterone is too short. The metabolism is too heavy. And then my suggestion is to use eventually micronized progesterone transvaginally.
Yeah, very clear. And there's a question on using HRT in surgical induced menopause in women with a history of endometriosis. So women receives
yes.
salpingo oophorectomy or an hysterectomy as well. And can you use, or which type of HRT would you use in this type of person?
You know, I think that if they've been hysterectomized, you can use only estrogen therapy, estrogen administration. You have to evaluate what kind of estrogen, better transcutaneous estrogen. I would like to give them not so much a patch, but a gel, a transcutaneous gel. This brings also to slightly higher concentration of circulating estradiol. This is strongly supportive for the brain. And I don't think that the fact that she had an endometriosis can modify absolutely the clinical picture or expose the patient to any possible risk.
Okay, there's a couple of questions on the use of androgens, particularly on testosterone. One asks about the use of monthly injectable testosterone enanthate associated to estradiol valerate. And the other one is on the use of testosterone to counteract breast stimulatory effects. Would you like to comment on these two possible uses?
Yes, I would like first of all to, I'm sorry that in Italy we don't have enanthate testosterone, enanthate for women use associated to estradiol. Then we have not that experience. Probably my British colleagues, they have a bigger experience on the topic. But speaking about the use of androgens, I would like to mention that women that are not only suffering from the lack of androgen coming out from the ovaries after menopause or mainly after surgical menopause, but they have also the normal physiologic lack of androgens originating from the adrenal gland. Then I think the idea of Labrie to provide the hormones who by the intracrine effect that they can be metabolized to other androgen or to estrogen, such DHEA. The treatment with DHEA is something that where I have a huge experience. I am using since long time, because I think that women, it's not women during their life, they suffer the androgen lack. The androgen, the higher concentration of androgen are just at the end of the adolescence, when they're in the youth times, when their brain are very sensitive, but not only the brain, also the bone, the muscular structure, and also all the human body have a strong androgenic impregnation at that time. Since that moment, they decline progressively. And if you take out the ovary, even more. Then I am personally in favor of an androgen supplementation too. When speaking about menopause hormone therapy, and you know very well, Tommaso, my beliefs on that, I think that also we have to measure DHEA sulfate. If DHEA sulfate is lower than 1 microgram per milliliter or 1 milligram per liter, I think the woman, she needs also an androgenic supplementation by an androgen who can be considered the physiologic most important androgen prohormone that the women have. I would like to remind you that DHEA sulfate circulate in fertile women in concentration of around 2 microgram per milliliter, 2 microgram per milliliter, while other androgen, they are all in concentration of nanogram or picogram. Then it's very important to think about for the future to the importance of this general precursor of androgen and estrogen for the women body.
Yeah, a last question for now on the menopausal part. There was one person from the audience saying that dydrogesterone is usually not enough for endometrial shedding in perimenopausal women. So it's less effective than other progestins to this extent. So he is asking whether dihydrogesterone in cyclic menopausal hormone therapy, whether it is enough to protect the endometrium against hyperplasia in the long term.
Okay, all the data seems promising in that sense. You can give 10 or 20 milligrams a day of dihydrogesterone starting from around day 12 or 13 of the cycle. Then even before the moment of the expected ovulation, these do not interfere in the ovulation mechanism. I was mentioning that one in my presentation, and you can give that one supporting until day 24, 25. Then you stop, and this brings a sufficient amount of biologically active molecule to provide the changes of the endometrium who are indicative of the safety of the molecule for the prevention of hyperplasia, atypical hyperplasia, and also endometrial carcinoma.
Great, thank you. A couple of questions for Professor Ott now. I'm sorry, I'm not sorry. We are happy that there's such a vast number of questions, but I need to stress you both with this repeated number of questions. But it's very entertaining. So there's two questions on progesterone and pregnancy. Particularly, one is about the appropriate good levels of progesterone in the first 8 weeks of pregnancy. What should be considered optimal or at least sufficient in terms of progesterone levels at the beginning of pregnancy?
So usually we have the distinction between a pregnancy at risk, including extrauterine pregnancies and viable pregnancies. The cutoffs lie somewhere between 25 to 30 nanogram per milliliter in all those studies to distinguish between these kinds of pregnancies. On the other hand, there is not so much literature about what progesterone level should be derived at when you're providing the patient with micronized progesterone. So usually you will use the standard doses and do not think anymore about how high the progesterone level would be. And in addition, if you give an oral dihydrogesterone, that has no effect on the progesterone level that you can observe.
Okay, thank you. And there's a question on the use of dihydrogesterone or oral progesterone for treating threatened abortion. And the question is it better using one or the other compound? What is the evidence?
That's a good question. So going back to this network meta-analysis from Deval et al. Last year for threatened miscarriage with a woman who already has some slight bleeding and has already suffered from one or more miscarriages before. Obviously, micronized progesterone applied vaginally is better than dihydrogesterone. So that's what the meta-analysis says. And they usually use 400 milligrams micronized progesterone per day. So that would be, for example, 200 milligrams capsules per day vaginally. But as I said before, my approach is to give both of them. So it's dihydrogesterone orally and micronized progesterone vaginally in order to be on the safe side, because there are some other meta-analyses, as I said before, which say the contrary, and that's a little problematic.
Okay, thank you. Since you touched on the use of different routes and formulations, there's a question on the use of vaginal progesterone. And the question is, what vaginal progesterone options are available here in Europe, and which one is more practical particularly for long-term use? Because of course, if you use a gel, it's more complex, it's messy. Yeah. So what do you use actually in your clinical practice?
Yeah, what we use is, I'm not sure, am I allowed to say preparation names? Am I allowed to say names of specific preparations? Yes. So what we use basically is Arefam in Austria. So that's a capsule containing 200 milligram. micronized progesterone, and it can be applied vaginally, or Progestogens only has 100 milligram. We do not have much experience with the gel, honestly. So we don't use that in Austria very often, especially not in the IVF setting. Don't know what it's like in Italy.
Yeah, it's very similar. So most of the persons in Italy use progesterone transvaginally in capsules, that are easily dissolved. Yes, that's the most common type of approach. Other questions on menopause, so for Professor Genazzani. There's a question on the comparison between the association of transdermal estradiol with the intrauterine levonorgestrel releasing IUD as compared to Tibolone. Well, the question is, which is better? But I don't think it's a.
I think
there's a better one. But how do you use the two approaches?
I think are very different approach of treatment. And then what you have to believe is the fact that Tibolone is also provided of some central androgenic effects, and then Tibolone is have a very strong mood protective effect, and an interesting effect protecting female sexuality, and then for its androgenic activity. This is one of the typical effects. And certainly in comparison to the use of at the same time of an intrauterine device and a patch or a gel or an oral treatment, it's more easier to make a single administration of Tibolone, a capsule, a tablet or half tablet a day according to the needs. But I would like to answer also something related to what Johannes was mentioning, the possibility to use dydrogesterone and progesterone. Also, because, progesterone given per vaginal way, even less than orally, but provide higher concentration of allopregnanolone too later on. And then this in women that in climateric time and in after menopause, they complain for sleeping problems. The use of progesterone is certainly of a very important help. In the night, to use an administration of progesterone, a capsule of progesterone in the night, which, if it's not sufficient to provide an adequate endometrial protection in 100 milligrams, you can also add within the morning half tablet or one tablet of dydrogesterone too. Then the progestogenic treatment have to be taken in observation with the possibility to use, according to the patient, to use an individualized therapy.
Right. So thank you. And two questions on Tibolone. There's an interest in this. One is whether it's possible to use Tibolone after 60 years of age. And the other one is what are the cerebrovascular risks with the use of Tibolone? Would you like to address both questions?
Yes. Okay. First of all, I was already mentioning Tibolone is in tablets of 2.5 milligram. 2.5 milligram are what is needed to face the menopause symptomatology at the beginning. They are a very quite a strong effect. But going on with the age, I've also mentioned before, you can use half tablet a day, 1.25 milligram, absolutely sufficient after the first years of postmenopausal therapy. Then in the women over 60s, I would like to go to half dosage. And concerning the stroke, there is a huge studies evaluating the possible risk of the stroke associated risk with Tibolone. But at the end, I think that we can be strongly reassured that there is not represent a reason to why we cannot use this treatment, and then this is not increasing the stroke risk.
Well, since we are discussing right now about cardiovascular or vascular risks, there's a question on the use of hormone replacement therapy in women with cardiovascular symptoms, for instance, angina pectoris. So is this feasible? Does it have positive effect?
Absolutely, yes, absolutely. I would like to remind you that one. Absolutely, yes. But you have to better understand how you can to give. you can give estrogen by transdermal route. You have not to give estrogen orally, because this can have effect on protein C resistance. It can have effect on the induction of protein from the liver, which can represent a further risk at cardiovascular level. Then only transcutaneous or transdermal estrogen administration. And also in those patients, you have to select the proper progesterone. Then you have to give either progesterone transvaginally or oral detrogesterone. Then this is fundamental. Not to take out these women from the possibility of therapy. You have to send them to the cardiologist first to be treated for the specific disease and make specific prevention therapy, but you can add transdermal estrogen and progesterone or detrogesterone.
Right. There's a question, Professor Genazzani, I think still for you, which is, I think it's a difficult one. The question is on, is it possible to use micronized progesterone or dihydrogesterone in women with breast cancer who are on tamoxifen for the benefits of these two molecules, specifically to protect the endometrium from tamoxifen effects? Would you like to comment on that? Yeah.
It's a difficult question and a difficult answer, but the answer is not difficult. No studies have been done in this patient. Then this is my response is associated to my responsibility. Then generally speaking, the treatment have not to be done because we have not sufficient experience on that patient. This is what I think. So I don't know, Tommaso, if you are...
I completely agree. And there's no data, to my knowledge, that progesterone administration can counteract tamoxifen effects on the endometrium, which are depending on the specific way that tamoxifen serves.
And also I would like to mention, as I've already mentioned, that the tamoxifen effect on endometrium, they're not the same effect that a progesterone can protect on endometrial exposure to estrogen. This is a typical kystic hyperplasia who have under tamoxifen as well as under other kind of SERMs, which do not represent the same biological model of hyperplastic endometrium.
Okay, so just a last question to both of you. We have a lot of other questions, but we are heading towards closure. So final one. There have been several questions on endometriosis. And I wonder whether you would like to comment on, for instance, Johannes, on which progestogen will you use for women with endometriosis, maybe in fertile life, and for Professor Genazzani, whether there's any preference related to progestin in MHT in women with an history of endometriosis. Johannes, you want to start?
Of course. So if I got that right, the question is what kind of progestogen in cases of endometriosis, but a woman who wants to conceive?
Yeah, not necessarily. So the question is about use of progestogens for endometriosis. Okay. So it could be for women who want to conceive. So you may want to address that as well, but also for the management of symptoms.
For the management of symptoms, the progestogen that I usually prescribe is Dienogest, because it has the most favorable effects on the symptoms and the associated pain symptoms and the highest pain relief. And usually if the patient is affected very intensively, of course, probably with a long cycle, oral contraception, of course. And the other thing is, if we are dealing with a patient who has severe adenomyosis and related symptoms, then it's a more local problem there. Also, the hormonal intrauterine device with levonorgestrel, I think, is a very, very good option for these patients.
Professor Genazzani, do you choose any specific progestin for menopausal treatment?
Okay, first of all, you have to avoid menstruation. Then you have to protect the woman, but she have not to menstruate. Then no sequential therapy, only continuous therapy. And for continuous therapy, you can either start from climacteric premenopausal time, and then in this way you can also use an intrauterine device with levonorgestrel and administering a continuous administration of transcutaneous estrogen. And later on in the menopause, I also support the continuous treatment with low dose transcutaneous estrogen, and you can also give either you can also give if a progestogen, and this should be low dose of vaginal micronized progesterone, or 10 milligram dydrogesterone orally can be also given in a continuous way without any deterioration of the local situation.
Okay, well, thank you so much. You were absolutely clear, and I apologize to all of the persons who actually sent questions, but there was no time to address all the questions. It was a huge audience. So we are moving towards conclusion. So it's my duty to thank both the speakers, Professor Johannes Ott and Professor Andrea Genazzani, for being such outstanding teachers with these two very broad areas of clinical relevance that they had to discuss today. I would like to thank ABBOTT for supporting this beautiful webinar, and the ISG for organizing this series of events. These webinars are absolutely useful, I think, for everybody in the world. As you can see on the screen, we are going to have in May, from May 11 to May 14, the 20th Congress, of the World Congress on Gynecological Endocrinology. It's a traditional event right now. It's, I think, the foremost event where gynecological endocrinology and reproductive issues are discussed worldwide. So I'd like to remind you to look at the website and to consider registering and coming, because this will be an in-presence meeting. So hopefully we'll be able to meet all in person and to enjoy science and the beauty of Florence. But I would like also to remind you that the ISG, specifically the educational branch of ISG, the International School of Gynecological and Reproductive Endocrinology, is organizing a fantastic online course that is made out of 13 webinars on menstrual cycle disorders. You have to look on the website, searching for the ISGRE website and the event. You will see how rich and interesting is the program. The program has already started, so the first webinars have already taken place, but they're registered. So they're recorded online. So if you want to participate, you can jump on the train and you will be able to see those webinars that were already done, and you can, of course, see the live webinars that will come from now to July. So thank you so much for attending this wonderful webinar, and I look very much forward to the next one. Thank you, ISG.
Thank you, Tommaso. Thank you, Johannes.
Thank you so much.
Have a good day. You too.